This session is on indications for urinary diversions in adults. By far, the most common reason for urinary diversion in adults is cancer of the bladder. Almost always it's transitional cell carcinoma of the bladder because the bladder is lined with transitional cell epithelium. Bladder cancer is much more common in men than in women. The major risk factors are cigarette smoking, exposure to industrial dyes, and industrial contaminants. So you can understand why it would be more common in men than in women. It does occur in women, but it's much more common in men. So here you see the different stages of bladder cancer. Now, if you have stage 0, where it's carcinoma in situ and you have tumors sitting on the surface of the bladder, that patient may not require removal of the bladder. They may very well be able to go in there and simply remove that very surface tumor. However, once the tumor begins to invade deeper layers of the bowel wall, you'll see the term muscle invasive transitional cell carcinoma. Then the standard of care is to remove the entire bladder, and in men to also remove the prostate gland. So you can see here why they would have to remove the prostate gland. And I will tell you that this is being reconsidered. They're doing further research. But at this point in time, if you have a male patient with bladder cancer, curative resection involves removal of the entire bladder and removal of the proximal urethra. And as you know, in men, the proximal urethra is surrounded by the prostate gland. There is no way to effectively remove the proximal urethra without removing the prostate, because the prostatic tissue and the urethral tissue are so attached that you cannot separate them. So at this point in time, curative resection for bladder cancer in men involves removal of the bladder, the proximal urethra, and the prostate gland, and is known as cystoprostatectomy. Now, as you see on the slide and on your handout, that has major implications for sexual dysfunction. We'll come back to this in a later class on sexual counseling for the ostomy patient, but I want to just briefly explain to you that the prostate gland is the source of seminal fluid. So the seminal vesicles actually empty into the prostate gland. The sperm then mix with the prostatic secretions to form seminal fluid. If you remove the prostate gland, you remove the seminal vesicles and you remove the source of the seminal fluid. So cystoprostatectomy automatically means loss of ejaculatory function. And men who are still interested in having children should bank their sperm prior to surgery. The other thing that you need to know is that the nerves that control erection pass right through the prostatic tissue on their way to the erectile tissue in the penis. So if you do a standard cystoprostatectomy, remove the bladder, the prostate gland, you will remove a section of that critical nerve pathway, and that patient would also lose erectile function. However, the standard of care in 2013, and we will go back to this, is what they call a nerve-sparing cystoprostatectomy. When they do a nerve-sparing cystoprostatectomy, they remove the bladder, they remove the prostatic tissue, but they preserve the nerve pathways that are coming through the prostatic tissue to try to preserve erectile function. Fortunately, the nerve pathways that control sensation and orgasm pass through a totally different tissue planes, do not pass through the prostate gland at all, and so are unaffected. So to summarize, if a male has a cystoprostatectomy, sensation and orgasm will be unaffected. Ejaculatory function will always be lost. If they do a nerve-sparing cystoprostatectomy, erectile function is typically regained after an initial recovery period of about 6 to 9 months. Again, we'll come back to that later, I just want you to know at this point that for a male patient who has urinary diversion for bladder cancer, they're dealing with significant sexual dysfunction in addition to having to learn how to take care of their ileal conduit, in addition to dealing with the diagnosis of cancer. Now, what are the other potential reasons for urinary diversion in adults? Well, women might require urinary diversion due to cervical cancer that has spread to involve the bladder. So you think about the anatomy in the female, and you think about where the cervix is. It sits right here. So if you have locally invasive cervical cancer, it can easily spread to involve the bladder. Also, if it involves the vagina, if you have cervical cancer that spreads distally into the vagina, the anterior vaginal wall and posterior urethral wall are essentially opposite sides of the same door. So you see that it's very easy to get extension of cervical cancer to involve the bladder and the urethra in women. So you will have a small group of women who have advanced cervical cancer and who require what is frequently known as an anterior excineration, where they remove the pelvic reproductive organs, cervix, uterus, tubes and ovaries, the proximal vagina, and they also remove the bladder and the urethra. So cervical cancer in women that's invasive may necessitate removal of the bladder and urinary diversion. Not common, but definitely possible. A very uncommon reason today to have a urinary diversion is incontinence that's not responsive to other therapies. We have so many methods for treating incontinence in 2013 that it's unlikely that someone would require a urinary diversion, but it is still sometimes done. So I have seen patients with spinal cord injuries who had a very hard time managing with intermittent catheterization who elected to have an ileal conduit because that gave them better control of urine elimination. So still a possible reason, just not common. And finally, you'll have some patients, or you might have some patients who have a urinary diversion due to refractory inflammation involving the bladder. This could be due to radiation damage causing refractory radiation cystitis. More commonly, it's due to what's also known as either interstitial cystitis or painful bladder syndrome. This is a chronic refractory inflammatory condition of the bladder. I sometimes compare painful bladder syndrome or interstitial cystitis to inflammatory bowel disease in the GI tract, where you have recurrent inflammation, the causative factors are not clear, and management is frequently not clear and not always effective. So the potential, I want to go to the next slide because the next slide has the key points. But what you see here, you see a woman in a lot of pain in the bathroom. You see that she has an inflamed bladder, if you can see that. And you'll see on the next slide that the thinking in terms of, what causes interstitial cystitis, what causes painful bladder syndrome. In men, it can be prostatitis, cystoprostatitis. They think that there's damage to the lining of the bladder wall, and that this damaged urothelium or damaged lining to the bladder wall allows irritants in the urine to pass through that lining and to penetrate the bladder wall and trigger acute inflammation. Now, one of the things that you frequently see on cystoscopy are these microscopic little glomerulations. So that's one of the classic indicators when you see these little starburst hemorrhages in the bladder wall. So going back to this, I just want you to know a little bit more about this. I'm not going to test you on it, but I wanted you to have it in your material so that if you have a patient, you can go back to this. These patients have such a hard time, they need so much support, so I want you to at least know the basics about this condition. Even though it's not extremely common, it is no longer rare, And so I think that as a WOC nurse, you're fairly likely to meet a patient who has interstitial cystitis or painful bladder syndrome. So we talked about the cause being unclear, that we think, or that the researchers think, not me, the researchers think that there's some abnormality in the lining of the bladder wall that allows irritants in the urine to penetrate and to trigger an inflammatory process. We are very clear on clinical presentation. Patients with painful bladder syndrome or interstitial cystitis present with frequency, urgency, and pain, the classic signs of bladder inflammation. Now, we associate those signs with a urinary tract infection. And many times, because most of these patients are female, when they first go in with this constellation of symptoms, they're treated as if they have a urinary tract infection. But then when they do follow-up, they fail to respond to antibiotics. And when they do follow-up, they find they're not infected, but they have all of the classic symptoms. Now, some 20, 30 years ago, before this condition was more widely recognized, a lot of these women were labeled as being hysterical and difficult because they kept coming back with the same symptoms, even though they clearly had no infection. Fortunately, now we know a lot more about this condition. Hopefully, patients are diagnosed much more quickly. Hopefully, they find a urologist who is knowledgeable and empathetic and can help them to manage their symptoms. So how do we treat them? Well, first we have patients keep a food and fluid intake and symptom chart so that they can see which foods and fluids are most likely to trigger a flare-up, to cause symptoms. Many times it seems to be foods and fluids that have high potassium content, things that are like tomato-based or that are citrus-based. But there's some differences for each patient, so it's very helpful for them to identify their triggers and then to make dietary modifications. There's also a product known as Pre-Leaf, and I think I gave you the generic calcium glycerophosphate that they can take prior to ingesting any tomato-based, citrus, or alcoholic substances that frequently minimizes the pain, minimizes the symptomatology. There are two major groups of medications that are used for these patients. One medication is Pentosan, and what it does is it helps to gradually restore that protective layer or lining of the bladder, the glycosaminoglycans layer or the GAG layer. But it takes months to take effect. However, that's still considered the first-line therapy by many urologists because in some patients it has been very effective in reducing symptomatology. The other commonly used group of drugs are your tricyclic antidepressants. And it's not so much for the antidepressant effect, although I think that couldn't hurt. But the primary reasons for using these medications are to restore normal sleep patterns and to help reduce pain because of the beneficial effect of tricyclic antidepressants on pain perception and pain pathways. They do some bladder installations. There's a wide variety of bladder installations they've used to try to reduce inflammation in the bladder. Some patients benefit from routine hydrodistension under anesthesia so that they might distend the bladder to where it holds like 400 cc's, and that will give them temporary relief because one of the things these patients tell you is they cannot tolerate any significant volume of urine in the bladder. As soon as the bladder starts to fill and stretch, they're in acute pain. Some of them void once or twice every hour just to get temporary relief. So those patients are likely to benefit from routine hydrodistension. Stretch the bladder out, improve bladder capacity, reduce that intense pain with bladder filling. It usually has to be repeated about every 3 months. You see that diversion is a very last resort, so they try everything else first. However, I will also tell you that some of the happiest patients I've had have been patients who had urinary diversion for interstitial cystitis. I remember one woman And I've only had a few, but I remember one woman, and when I went in to see her after surgery, I said, "How are you doing?" She's like, "I am doing great." She's like, "Did you know I slept all night?" She's like, "It was so wonderful to sleep all night, and I've been thinking this morning, I think I'm going to get my life back. I can learn to take care of this pouch. I know you'll show me how to take care of this pouch. I think maybe I'll get to travel again. I'm so excited. I feel like I've turned a page." That just tells you how severe the pain is. So, am I going to ask you about that? No. Do I want you to know about it in the back of your head and be able to access information? Absolutely. Okay, so what do I want you to take home from this discussion? That bladder cancer is by far the most common reason for urinary diversion. That it may be done for cervical cancer involving the bladder. Occasionally it's done for refractory incontinence or for refractory bladder inflammation. What am I most likely to ask you about? Bladder cancer. So now we're going to talk about the types of diversions that can be done. We're going to talk about what's been done in the past that you might still occasionally see, but we're going to focus primarily on the ileal conduit. That's the most common diversion at this point in time. So originally, the most common approach to urinary diversion was a ureterostomy, which makes sense because if you take out the bladder and you're the surgeon, you're standing there in the operating room with two ureters, and you've got to do something. So attaching them to the abdominal wall seems like a pretty simple, obvious, logical thing to do. So you understand what a ureterostomy is. You've removed the bladder, you've brought the ureters to the abdominal wall. Sometimes they bring them out on each side if the ureters are short. More commonly, if you have normal ureteral length, they try very hard to bring the ureters out side by side so they can be pouched together. Or sometimes they'll even connect one ureter to the other and then bring that one ureter out as a stoma. So, advantages to ureterostomy, very simple surgical procedure to do. Why aren't we seeing very many ureterostomies done in 2013? And the answer is because they're not a very satisfactory diversion. There are many, many complications, many disadvantages as opposed to one advantage. So the first major disadvantage is the fact that ureters are very narrow. So a ureter is only a 1/4 inch in diameter. And if you bring a structure that's only a 1/4 inch in diameter to the skin surface, sew it down, the skin naturally in the healing process is going to tighten around that, and it's going to take that 1/4 inch structure down to something like 1/8 of an inch or 1/16 of an inch. So one very common issue is progressive stenosis and the need for surgical revision. In addition, think of the fact that that very narrow tube has to pass through the abdominal wall, through the muscle layer, and that it's very likely that that tube is going to be compressed, especially if you bring it through a fairly thick abdominal wall. It's kind of like taking a straw and putting it in a thick book and closing the book. You're going to compress the straw. So compression causes poor emptying. So stenosis, compression, end result, poor emptying, some back pressure on the kidneys. What else? Well, look at pouching issues. You're going to end up with very tiny little stomas, and they're not true stomas. I mean, well, they are true stomas, but there's no real protrusion. They usually barely get the ureter to the abdominal wall and get it stitched down, so you don't have any kind of protruding budded stoma. So you have this tiny stoma. Many times you can't elect the place where you would like to have the stoma. They end up bringing the ureter out at a point where the ureter will reach the abdominal wall. So I remember having a lady who had bilateral ureterostomies, and she literally had to pouch here, looking in the mirror, pouch here, looking in the mirror, because her ureters had been damaged by radiation. And once they resected the very stenotic damaged sections, they had very little ureter to work with. So sometimes ureterostomies end up in very pouching unfriendly locations. So pouching is frequently an issue. And then think about the fact that any organism that gets into the pouch has ready access to the stoma, and then it's a straight shot to the renal pelvis. So poor emptying, high incidence of stenosis requiring surgical revision, major pouching difficulties, and high incidence of urinary tract infection. That's why you rarely see ureterostomy in 2013. Okay, what else could be done? So here's a procedure that you're even less likely to see than a ureterostomy. Vesicostomies are even less common in the adult population, although, as you will hear, they are sometimes done as a temporary diversion in the pediatric population. So what is a vesicostomy? Well, you put the words together. Vesico means bladder. Ostomy means opening. So a vesicostomy is an opening into the bladder. I call this a buttonhole type diversion because basically they make an opening into the abdominal wall. They grab the bladder. They make an opening into the bladder wall, just a transverse incision. Then they sew the bladder wall and the abdominal wall together, just as you would sew a buttonhole together. So opening directly from the abdomen into the bladder. Now you can immediately see that there are tremendous limitations when you think about a vesicostomy. First of all, you can't do a vesicostomy in a patient with bladder cancer or bladder inflammation because in those situations you need to either remove or bypass the bladder. So vesicostomy is an option only when there is no bladder pathology. And urinary diversion is typically done for bladder pathology. The one time that it may be considered is in a child who has some kind of obstructive process involving the urinary tract, and then a simple opening into the bladder would make a very good temporary diversion. I have also very occasionally seen it used as an option for an adult who had refractory incontinence, but it's not a good choice in an adult because in an adult the bladder is essentially a pelvic organ. And if you do a vesicostomy in an adult, you end up making a little opening into the very top of the bladder, and it's right at the pubic hairline. So it's a very difficult site to pouch. So hopefully you will never see a vesicostomy in an adult. As you see, it's usually reserved for temporary diversion in children. Disadvantages of vesicostomy, think about the fact that most of the time the opening in the bladder is going to be toward the top of the bladder, especially in older children. And so you're going to get kind of an overflow emptying. It's going to be emptying at the top or the midpoint of the bladder, not at the bottom of the bladder. Also, straight opening into the bladder, so infection is not uncommon. And pouching is almost impossible because you end up with this slit kind of opening. When the child sits, it's usually in a crease. But remember that this is typically done in children as a temporary diversion to relieve obstruction in the urinary tract. And so most of the time we just diaper these kids until we get the vesicostomy closed. I don't want you to worry about vesicostomy at all until we talk about urinary diversions in children. I'm just mentioning it because occasionally it's done in adults. It is not considered a diversion of choice in adults. So all of your questions about vesicostomy will be tied to the pediatric population, and we'll discuss that in a later class. Now, by far the most common type of urinary diversion in 2013 is the intestinal conduit, and specifically the ileal conduit. So I wanted to go through the basic concept, and then I wanted to go briefly through the surgical procedure. The basic concept is, instead of trying to attach the ureter to the abdominal wall, what we're going to do is we're going to take a little section of bowel, and we're going to attach the bowel to the abdominal wall because we know that ileostomy stomas do fine, colostomy stomas do fine, low incidence of stenosis, relatively low incidence of pouching problems. So it's like, take this little piece of bowel, use it to transfer urine from the abdominal cavity to the abdominal wall. So take this little section of bowel, attach the ureters to that little section of bowel, attach the bowel to the abdominal wall. Use that little section of bowel as a pipeline, okay? So I'm going to go through the steps. I want you to understand the steps. You're not going to necessarily explain all of this to patients, but you need to understand it. So we've already said that the ileum is the section most commonly used. We'll come back to why that is. But here you see step one. You identify the little 6 to 10 inch section of ileum to be used. Then you're going to make an incision here and here. You're going to remove that little section of ileum. Notice that you leave the mesentery intact. So you make an incision into the mesentery to free up the section of mesentery that provides blood supply and innervation to this little section of ileum. Then I want you to notice that the bowel itself is reconnected. So you've taken out this little section of bowel that you're going to use to create this pipeline. And then you've reconnected the bowel so there will be no change in bowel function, an important thing to tell patients. Okay, so now the bowel has been reconnected. We have this little section of ileum, in this case, that we're going to use to create this pipeline. What they do is they close that section of ileum on the proximal end. You can see it very clearly here. You bring the distal end out as a stoma, and then you connect the ureters. So now urine flows from the kidneys through the ureters into this little section, this little channel or pipeline, and out through the stoma. You need to be very clear about the process used to construct an ileal conduit so you can explain it to the patient, but you want to explain it to them in their terms. We have to remove the bladder. We have to create an alternative pathway for urine elimination. We're going to do that by using a small section of your intestine. You have a lot of extra intestine, so this is not a problem. We take out a 6 to 10 inch section, or the surgeon does, and reconnects the bowel, so no change in the bowel. Now we have this little 6 to 10 inch section. We're going to sew it closed at one end, bring the other end out as a stoma on your abdominal wall, and connect the ureters. One very important point in talking with patients is the fact that this is literally a pipeline. It is not a reservoir. It's not a storage area. So the patient has to understand that urine is going to flow through this and out the stoma, and that urine flow will be almost continuous. So they will need to wear a pouch at all times. And we'll come back to that in our class on management of the patient with a urinary diversion. Now, ileal conduits are by far the most common type of intestinal conduits. We talked about that, but I want to go over why that is. Because you know how surgeons are. As soon as Dr. Bricker, he was the first one to come out with this concept. It was at Cleveland Clinic. So as soon as he, essentially published the concept of the ileal conduit and his initial success in managing patients with an ileal conduit, then other surgeons started thinking, well, I wonder if another section of bowel might work better. So they tried using the jejunum, because of course we have lots of jejunum. But go back to what we talked about in GI tract physiology when we talked about fecal diversions. What's the major function of the jejunum? And it's reabsorption of nutrients and of fluids. So when they created conduits out of jejunum, even though the urine passed through pretty quickly, there was still significant absorption of electrolytes out of the urine, transfer of electrolytes in exchange, and these patients got into some very serious and significant reabsorption syndromes. So now the jejunum is not used unless it's an absolute last resort. You do not want to use jejunum. So take jejunum off the table. Okay, then they tried using a section of colon, and they thought, well, you know what, we could use the colon. It's got those very thick muscle bands, the tinea, maybe we could kind of tunnel the ureters along the tinea and provide reflux protection. No, no better outcomes and a much more difficult procedure surgically. So we no longer use the colon unless there's some reason that we cannot use the small bowel. One surgeon even tried using the ileocecal section of the bowel, thinking that they could make the stoma out of the cecum, they could connect the ureters to the ileal section, and that might give some anti-reflux protection. Again, no benefits, and now you've taken away the ileocecal valve. So they've kind of wandered around the GI tract, they've tried the jejunum, they've tried the colon, they've tried the ileocecal area. One group even tried taking a section of stomach and tubularizing it, thinking that the hydrochloric acid would kill the bacteria and reduce the incidence of UTI. True, but the hydrochloric acid also washed out on the skin and caused major skin damage. So having wandered around the GI tract, what did they come right back to? The ilia and the ileal conduit. And I'm sure Dr. Bricker was like, I told you so. Okay, so do you need to know any of these details? No. Do you need to know that the ileal conduit is the most common type of intestinal conduit? Yes. Well, let me see where, hang on just a minute. I don't think I did put this in. So what I wanted to go over with you is that even though the ileal conduit does provide major advantages as compared to other intestinal conduits, even though it's a much better choice than a ureterostomy, there are still disadvantages to the ileal conduit. From the patient's perspective, it provides no urine storage and they have to wear a pouch continuously, and pouching can be a challenge when you're dealing with urine. More significantly, there is no reflux protection. The ureters are connected to the section of ileum, but in that connection, there's no ability to provide reflux protection that we typically have from our bladder. So one of the disadvantages of the ileal conduit is that bacteria can migrate up the ureters. Any bacteria that get into the pouch can migrate through the stoma, up the conduit, up the ureters to the kidneys. And so these patients are higher risk for urinary tract infection after they have their conduit than they were before. Because if you go back and you remember, your bladder is equipped with anti-reflux protection. You have that extra layer of muscle that surrounds the ureters so that whenever the bladder contracts, that muscle contracts and seals the ureters. And the ureters enter the bladder at that oblique angle that makes it much harder for urine and bacteria to migrate proximally. So those of us with an intact bladder are well protected against upper tract infection. But patients with an ileal conduit do not have good protection against upper tract infection. So we've taken away the bladder. We have connected the ureters directly to this little section of ileum. It's a very straight connection. And so any bacteria that get into the stoma and into the conduit have a straight shot up the ureters to the renal pelvis. Their best protection is fairly continuous fluid intake, because as long as you're drinking fluid and making urine, then urine is flowing down the ureters and out and flushing bacteria out. But if you go for a period of time with no urine production because you went for a period of time with no fluid intake, then you turn the conduit into a dry creek bed, and it's very easy for the organisms to migrate upward. Hang on just a second so I can catch up with myself. I apologize. Okay. Now let's talk about complications of urinary diversion. When we talk about complications of urinary diversion, we're talking about complications of an ileal conduit. Now, we divide complications into the early perioperative period, which is like the first 30 days after surgery, and then long-term complications. One complication during the early perioperative period is the potential for extravasation. Extravasation can occur. You can leak urine out into the abdominal cavity if you have breakdown of the anastomoses between the ureters and the ileum. So you see these little straight-on connections. Or if you have breakdown, the anastomosis closing the proximal end of the ileum. So any anastomotic breakdown permits urinary leakage out into the abdominal cavity. And you think, well, urine's sterile, so you don't have to worry about bacteria. But think about this. Patients who have an ileal conduit have undergone extensive bowel prep and have been on antibiotics to cleanse that section of ileum that we're going to use as the conduit. That means there's overgrowth of yeast organisms. So if you start flushing urine out into the abdominal cavity, you're flushing yeast organisms out into the abdominal cavity, and then they're at risk for candida peritonitis or even septicemia. So a major leak can be a very serious complication. Critical for us to pick up on any evidence that there is an anastomotic leak, and of course the indicators would be excess drainage, either leaking through the incision or through the surgical drains, rapidly developing abdominal distension with increased pain, all accompanied by decreased output through the stoma and through the stents. We'll come back to that again, but it's very important for us as ostomy nurses to be monitoring our patients early post-op, monitoring fluid intake, IV fluid intake, urinary output, and where is the urine coming from. If we have any reason to suspect anastomotic breakdown, critical for us to notify the physician, because the earlier that anastomotic leak is identified, then the earlier they can put in a drainage catheter to eliminate urine from the abdominal cavity. Small leaks can usually be managed with drainage. Large leaks typically require taking the patient back to surgery. Now, the second complication that can occur, stomal ischemia. We'll have a whole class on stomal complications, but I'll just go in and mention that if the stoma is going to become ischemic or necrotic, that is most likely to happen within the first 24 to 72 hours post-op, because most of the etiologic factors for stomal ischemia, stomal necrosis, occur during the intraoperative period. Stripping too much of the mesentery when you are getting ready to make the stoma, or throwing a little clot to a mesenteric vessel that causes necrosis of the stoma, or massive edema of the stoma that compresses the little vessels and causes stomal ischemia and necrosis. Bottom line for us, every time we check that patient post-operatively, we should be looking at the stoma very carefully to make sure that it's still moist and red and healthy. If we see any evidence of stomal necrosis, we need to get out our little test tube, put the test tube into the end of the stoma, shine our flashlight to make sure that the necrosis does not involve the proximal bowel. Again, you're going to hear that repeated in a later class. And then, as you already heard, sexual dysfunction in men undergoing cystoprostatectomy because they've lost the prostate gland. That means they've lost the capacity for ejaculation. Remember that the nerves that control erection pass right through this prostate gland, even though the standard of care in 2013 is to do a nerve-sparing cystoprostatectomy. When they scrape all of that prostatic tissue off of that nerve is going to be damaged. And so most men do get erectile function back, but it usually takes 6 months or 9 months to get that back. So those are the most common short-term complications. What about long-term complications? The most common long-term complications are either recurrent infection and stone formation or renal damage. Actually, most adults do very well with urinary diversion. But if you look at the potential for recurrent infection and stone formation, we've already talked about the fact that patients with a urinary diversion, patients with an ileal conduit, are much higher risk for infection than someone with an intact bladder because they've lost that anti-reflux protection. And it's much easier for bacteria to migrate all the way up to the kidneys. and to cause pyelonephritis. So they are definitely higher risk. Now, if there's poor drainage from the conduit because it's excessively long or kinked, that increases the risk. That's very uncommon. Surgeons are very good at creating short, straight conduits. But look at the next reason. What if there's inadequate fluid intake? So you're not flushing the bacteria out and you are allowing them to migrate upstream. Then that's going to significantly increase the risk, okay? That's why we talk to our urinary diversion patients about fluid intake starting pre-op, and they'll never shut up. That's what they would tell you. Patients who have pre-existing renal disease, renal damage, are higher risk. And then some patients get into a vicious cycle where they get a very aggressive infection with an organism like Proteus. And then Proteus alters the pH of the urine, makes the urine alkaline. That increases the risk of stone formation. If they get a stone, then that blocks normal drainage, which increases their risk for infection. If they get another infection with Proteus or Pseudomonas or whatever, then again, you're right back to changes in the pH. So you can get into a vicious cycle of infection stones that compromise renal function long term, and that tremendously increase the risk of infection. But that's very uncommon. Most of our patients have no pre-existing renal disease. For most patients, it's all about teaching them right up front, you've got to drink plenty of fluids, and you've got to drink fluids on an ongoing basis so that you're constantly flushing the system, washing out any bacteria. That's your take-home message. That's what I want you to remember. That's what we're definitely going to ask you on the test. Renal damage, yes, can occur, but it's very unlikely in the adult population. Very unlikely unless the patient had pre-existing renal damage or they get into that vicious cycle with recurrent urinary tract infections. So take-home messages. Most common reason for urinary diversion in adults, bladder cancer. Patient most likely to have bladder cancer and require urinary diversion, male. Procedure most likely to be done, cystoprostatectomy and ileal conduit. In terms of types of diversions, I want you to know that ureterostomy is no longer done on a routine basis because of poor drainage, high risk of infection, difficulty with pouching. I won't ask you about vesicostomy in relation to adults. All of your questions about vesicostomy will be related to children, which we'll cover in a later class. I want you to be very clear about how they construct an ileal conduit, because you've got to be able to explain this to patients. So I want you to know that the basic concept is that ureter is too small to feed through the abdominal wall and to be attached to the abdominal wall without getting into problems with drainage. But if you interpose a section of intestine, which is at least 4 times as large as the ureter, then you can safely transport urine from the abdominal cavity where the ureter is to the skin surface. So how do they do it? Go back. They isolate a section of ileum. They reconnect the bowel. They bring one end of the stoma to one end of the ileum to the abdominal wall of the stoma. They close the other end. They connect the ureters. Constant drainage. The patient has to wear a pouch at all times. What are the advantages of ileal conduits? Better drainage than a ureterostomy. Better outcomes, fewer complications than any other type of intestinal conduit. What's the downside? What's the disadvantage of an ileal conduit? You have to wear a pouch at all times. Urine flow is pretty much constant. The other big disadvantage is that there's no way to provide reflux protection. So bacteria that get into the pouch, into the stoma, can go straight up to the kidneys unless there's fairly constant urine flow to flush those bacteria out. Those are your big take-home messages that I really want you to remember. Okay, thank you very much.